Hi everyone, I'm Gemma. I'm one of the residents at Nepean Hospital, and today I'll be going through some principles of antibiotic use in surgery. Hope you find this helpful, especially for those who are starting on surgery. Here's an outline of the talk. We'll go through some risk factors for surgical infection, how wounds are classified, some examples of local and systemic infections involved in surgery, how to prevent these infections, how to use antibiotics, the organisms commonly involved, antibiotic classes, and to end with some examples. Let's start with the question. Which of the following demonstrate the best way to stop infection perioperatively? Is it A, stopping immunosuppressive agents before surgery? B, giving the highest dose allowed of appropriate antibiotic? C, avoid the use of local anesthesia. D, remove foreign bodies and devitalize tissues in dirty wounds. Or E, insert drain after cholecystectomy. I'll give you a moment if you want to pause the video. The answer is D, remove foreign bodies and devitalize tissues in dirty wounds. Throughout this talk, I'll go through the reasons why A, B, C, and E are incorrect, but in general, the best ways to avoid surgical infection is to give the best antibiotic coverage at the most appropriate dose, and also to remove foreign bodies and devitalized tissues in dirty wounds. So what are the risk factors in surgical infection? I have grouped this into three classes, or three types. One is the host response. So for hosts who have, say, metabolic disorders, such as malnutrition, obesity, diabetes, or for those who are immune suppressed with, say, chemotherapy, immunomodulators, and steroids, these patients will have very bad wound healing, and hence they will lead to increased risk of infection. The surgical technique is important because good surgical technique can help to maximize and preserve the vascularity and the health of tissue being invaded. If it is poor technique, this can lead to increased amount of local ischemia, devitalized tissue, excessive dead space, and potential formation of hematomas and system compromise. Lastly, the pathogen involved. Some hosts will have been colonized with, say, vancomycin-resistant Enterococcus, or that they have MRSA, like methicillin-resistant Staph aureus, or ESBLs, like extended spectrum beta-lactamase, which can inhibit and resist a lot of the antibiotics given beforehand. Hence, adequate antibiotic coverage is essential in preventing surgical infections. Let's go through some basics of wound classification. This can be done in many ways. I have shown you three ways to think about wounds. One is primary versus secondary. Primary meaning from the indigenous source of the host itself, or secondary meaning from a hospital-acquired infection. Wounds can be classified according to its depth, superficial, meaning it's dermal or epidermal, deep, meaning that it's affecting the muscle fascial layers, and organ space infection, such as those affecting the organs, leading to the formation of abscesses. More commonly, you will see wounds classified as the latter, whereas clean is when it is unaffected, non-inflammatory, with no entry into the respiratory, gastrointestinal, or genitourinary tracts. These are usually closed primarily or drained with a closed drainage system. Clean contaminated wounds are those that do enter these tracts. However, there is no evidence of infection and no major break in technique. For clean and clean contaminated wounds, we generally use a prophylactic dose of antibiotic if it is deemed needed. This is in contrast to contaminated wounds where there is spillage, say from the gastrointestinal tract, or that the tissue can be seen as inflamed and there is a break in the sterile technique. However, the difference between contaminated and dirty is that contaminated wounds do not appear to be purulent. Dirty wounds, however, is where there is existing infection or that there is traumatic wounds, devitalized tissue, pus that you can see, or that the viscera is perforated. Essentially, there is a source of infection identified already. For contaminated and dirty wounds, prophylactic antibiotic is needed, but it is also continued to treat the ongoing infection after surgery. Here are some examples of local infections. On the left, we can see there's localized erythema, and this demonstrates a cellulitis, which usually develops 3 to 4 days after the operation. It is usually due to infection with the skin commensal bacteria, such as Staph epidermidis, beta hemolytic streps, and the management typically includes flucloxacillin or cefazolin for a few days. On the right, it might be hard to see, but say it's someone that has this mass developed after a week of the thyroidectomy. This shows an abscess. And abscesses form usually a week after the operation. It is a mixture of organisms, and management would include drainage of the abscess, plus the antibiotic to cover the suspected bacteria involved. Complications of abscesses include sinus or fistula formation, so drainage is quite important. Now to some systemic infections involved in surgery. Bacteremia and sepsis can occur, and this is due to a mixture of organisms. Therefore, empirical antibiotics is used and is based on the suspected organisms. Gas gangrene typically is caused by Clostridium perfringens from military traumatic surgery and colorectal surgeries. Management include aggressive debridement of the wound area, as well as antibiotics, typically IV benzopenicillins. Subdermal gangrene or necrotizing fasciitis is occurring in people who are immune compromised. You may have heard the term Melanese synergistic hospital gangrene or Fournier's gangrene. These are all types of necrotizing fasciitis. And the wound is actually bigger than it appears when you see it. Management includes, again, broad spectrum antibiotics as with sepsis. Clostridium tetani are less commonly seen, but can follow implantation into wounds or tissue. Management again involves use of penicillin, aggressive debridement, and ADT injection if not already given. So just a correction, for gas gangrene, the antibiotic depends on the organism use, but typically from the penicillin group. So how do we prevent infections? I've grouped this into 3 areas. So preoperatively, we can optimize the patient's condition by, say, providing adequate nutrition for those malnourished, or to have good blood sugar level control for those with diabetes. Cleansing the skin using antiseptic technique, and hair clipping right before surgery. Antibiotics given before the incision. This is typically given, say, within 4 hours, or also known as the decisive period. The decisive period is defined as a time where our own inflammatory humoral and cellular defenses can be utilized. So antibiotics given within this time before incision can help to cover the infection prior to our own immune response can be developed. Intraoperatively, we can perform the condition as aseptic as possible in theatre. Use adequate debridement and good surgical technique to preserve tissues, and sending for culture contaminated or infected tissues during surgery. Post-operatively, we can ensure less infections by delaying the primary or secondary closure of contaminated wounds, using dressings that encourage epithelialization and granulation, and avoiding hypothermia perioperatively to ensuring supplemental oxygen at recovery. So let's go through the principles of using antibiotics in surgery. I've grouped this into 4 categories. So before initiating antibiotics, you need to consider the spectrum given. And typically, this is to cover the commensal bacteria that we already have. And to give as narrow a spectrum as possible, but to cover as much needed as possible. Delivery time is important, as we've already mentioned. The decisive period before surgery is typically where antibiotics are given. Sometimes on the ward you won't see it given because this is given by anaesthetist pre-induction. The length of time is important. So for clean and clean contaminated wounds, in practice, you may only see a dose of antibiotics given right before surgery or maybe continued for another 24 hours. For contaminated or dirty wounds, antibiotics will be continued for treatment for a longer period of time. Special populations, such as those with pre-existing endocarditis or risks of endocarditis, require more specific prophylactic management, and this is described in detail on the therapeutic guidelines online. For those, say, who harbor VRE or ESBL or MRSA, these populations will need better coverage, especially if they already had an infection with these organisms before, or there are methods to decolonize these. However, it can be complicated and depends on hospital policies. Let's go through the organisms then that is involved, usually the commensal bacteria that is already on our body. So from the oral side or mucosal side, we have gram-positive such as staph and strep, some gram-negative anaerobes such as Bacteroides and Candida. From the skin, we have gram-positives like staph epidermidis, and to pay particular attention to burn wounds because they can be infected with gram-negative Pseudomonas, gram-positive staphs, and fungal infections. From the respiratory tract, you may see pneumonia or infections with gram-negative Pseudomonas, Acinetobacter, Enterobacteriaceae, gram-positive such as staph, and fungal. In the abdomen, there is a mixture of gram-negative E. coli, Klebsiella, Proteus mirabilis, and anaerobes, as well as gram-positive such as Enterococcal fecalis, streps, and some gram-positive anaerobes. From the urinary side, we have Pseudomonas, Enterobacteriaceae such as E. coli and Bacteroides, as well as some gram-positives. Lastly, from the genitourinary tract, you may see coverage for gram-negative Neisseria or chlamydia, gram-positive such as staph and strep, and fungal infections. Here is quite an old slide which I have taken in my clinical school years, but I found extremely helpful to just think about different classes of antibiotics. This is not to be placed in memory, however, I just want to bring your attention to different big groups and broadly what they cover. In blue, we have the penicillins, the beta-lactams, and these have very good gram-positive coverage, especially for staph infections. When amoxicillin is combined with clavulanate acid, there is some gram-negative as well as anaerobic coverage as well. In orange, we have the cephalosporins, and this ranges from generation 1 all the way to generation 5 and beyond. The lower generations have only gram-positive coverage, whereas the higher generations also expand to broad spectrum coverage, including gram-negatives. So cefazolin, for example, is good at gram-positives and NMSS, whereas the 4th and the 3rd generation have some gram-negative cover. Moving on to, say, doxycycline or the tetracyclines, these are very good at covering gram-positives and is an alternative, say, to penicillins. And they also cover some other intracellular pathogens such as mycoplasma, or the chlamydias. Clindamycin similarly covers gram-positives as well as most anaerobes or atypicals. In pink, we have the aminoglycosides such as gentamicin. They have great gram-negative coverage, such as E. coli. The vancomycin, or the teicoplanin, and the glycopeptides are good at MRSA coverage. The imidazoles, such as metronidazole, have great anaerobic coverage. And lastly, the meropenams on the bottom in green have extended coverage of gram-positive, gram-negative, including Pseudomonas and ESBLs, but they do not cover MRSAs. Moving on to our first case. 18-year-old female with congenital Chiari malformation is undergoing surgery for intracranial shunt insertion. She reports some rash and nausea after using penicillin in the past, and her weight is 120. Is antibiotics indicated, and if so, which one? Firstly, this is a neurosurgery where there is penetration of the skin and all the way into the brain. And because of this, we need to cover the skin flora, and coverage is important because the brain itself lacks the immune response. So for all neurosurgeries, we need some gram-positive skin flora coverage, and as per therapeutic guidelines, we generally use cefazolin. The patient, however, have a rash and nausea, so some allergy, mild allergy or severe allergy to penicillin. So can we use cefazolin? The answer is yes, because cefazolin is a special type of cephalosporin whereby the structure is very different to the penicillins. Her weight is 120, therefore we need to give a weight-adjusted dose of cefazolin, and this is generally 3 grams. So the answer is cefazolin 3 grams IV, just before given before incision. Question 2. 26-year-old female is heading to theatre for presumed non-complicated appendicectomy. Pre-induction, she was given IV augmentin. Intraoperatively, it was discovered that her appendix has already perforated. How will you proceed with antibiotic management of this patient? Firstly, IV augmentin is given because it can cover the mixture of gram-positive, gram-negative, and anaerobes that exist in the gastrointestinal flora. However, perforation is really severe, and the wound is changed from, say, a contaminated or clean contaminated to a dirty wound, which will require ongoing antibiotic management. The answer is tricky because the surgeon may choose to continue IV augmentin, or he or she may change the regimen to a combination of 3 antibiotics: the ampicillin to cover gram-positive, gentamicin to cover the gram-negative, as well as metronidazole to cover the anaerobes. Alternatively, some may use, say, ceftriaxone and metronidazole, where the cef to cover the gram-positives and the metronidazole to cover the anaerobes. Of course, cef also have some gram-negative coverage. So the answer can be any of these 3 combinations. But the key to this is that the patient will require ongoing antibiotics because of the dirty wound, as directed, say, by culture or the histopathology. Question 3. 80-year-old male is undergoing total hip replacement following a fall with neck or femur fracture. He has previously been tested positive for MRSA on the skin swab and probable history of MRSA. Weight is 80 and creatinine clearance is 40. What is the most appropriate antibiotic? Firstly, the patient is undergoing orthopedic surgery with implant. With any implants in orthopedic surgery, we need to cover the gram-positive skin flora to avoid seeding onto the implant postoperatively. Therefore, cefazolin can be a very good choice. However, the patient has a probable MRSA infection in the past. Therefore, cefazolin does not cover for that, and the likely antibiotic use will be vancomycin. Vancomycin is dose dependent on the actual body weight. But secondly, vancomycin is also renally excreted. Therefore, a reduced creatinine clearance can affect excretion and increase the toxicity. Therefore, what we need to be aware of is to give a weight-adjusted but also a renally adjusted dose of vancomycin. Hence, the answer will be IV vancomycin using the actual body weight to calculate the dose, and in this case is 1.2 grams, however renally adjusted to 1 gram. And all kind of adjustments like this can be found in our Australian Medical Handbook online. Last question. 60-year-old gentleman with post-operative uropathy secondary to benign prostate hyperplasia is undergoing a TURP procedure. Incidental urine MCS prior to surgery grew E. coli, however patient is asymptomatic. Creatinine clearance is 80 and weight is 95. Is there an indication for antibiotics, and if so, which one? This is a tricky question. So the question really is, will you treat the asymptomatic bacteria before surgery? The answer is yes. For any invasive urological procedures, such as a TURP procedure, you will need to treat the bacteria beforehand, regardless of whether the patient is symptomatic or not. This is to avoid seeding of the commensal genital urinary flora into the bladder and for potential for infection. Therefore, what we need to give the patient is perhaps a course of oral Keflex prior to his TURP procedure. For the procedure itself, again, because we're inserting equipment into the genital urinary tract, we do need to give a dose of, say, something that covers the gram-negative flora, and hence gentamicin is a very good choice. Gentamicin again depends on the kidney function and also the ideal body weight. Therefore, the answer is to treat the E. coli UTI, and then prior to induction or the surgery, to give a dose of vancomycin, 2 milligrams per kilogram, which you don't really have to remember, but adjusted to ideal body weight. So here is some extra slides that really summarizes the therapeutic guidelines at the moment in regards to surgical prophylaxis for, say, head and neck surgeries, for vascular orthopedic surgeries, for urology surgeries, and obstetrics and gynecology surgery. All right, so the take-home message. 1. Antibiotics do not replace surgical drainage of infection or appropriate wound debridement. 2. Antibiotics should be administered within a decisive period, that is, say, within 1 to 2 hours prior to incision, to cover for our lack of humoral and cellular response. 3. Factors affecting selection of the antibiotic include the likely pathogen involved, and in our cases, it's usually the commensal flora. The pharmacology, as for some medications, this involves taking into account of the weight of the patient and whether the patient has any kidney issues. No antibiotic resistance, such as those patients with VRE, ESBL. The side effects, especially those that say have a penicillin allergy or hypersensitivity, and the cost. 4. Organism and sensitivity should be determined if possible. And finally, re-evaluate if there is a poor response in 3 to 4 days. And if in any doubt, please contact the infectious disease department who can help you out. Thank you for listening. I hope this was helpful for you. And if you have any questions, please feel free to contact me.